Vincent Kennedy is gonna read the next paper. The title is Towards an Orthodox Christian Understanding of Opioid Agonist Therapy for Opioid Use Disorder. Dr. Kennedy is a psychiatrist with an additional board certification in addiction medicine and forensic psychiatry. He serves as an assistant professor of psychiatry and behavioral health at Penn State and attends Christ the Savior Orthodox Church in Harrisburg, Pennsylvania, with his wife and 3 children.
Yes. Okay.
Take it away.
Opioid agonist medications, including methadone and buprenorphine, are medications approved by the United States Food and Drug Administration for treatment of opioid use disorder, or OUD. These medications, similar to opioids that people misuse, also act on mu-opioid receptors. An Orthodox Christian perspective on opioid use disorder may be informed by precedents set by other substances that people use in excess and to their detriment: alcohol and food. Therefore, an Orthodox Christian perspective on the appropriate practical approach to contending with opioid use disorder can be informed by the precedents set by these other substances. Specifically, it is excessive and harmful use rather than any and all use that Orthodox Christian teachings discourage. Opioid agonist therapy, or OAT, for opioid use disorder represents an appropriate, moderate, limited, and controlled use of an opioid to prevent problematic and often lethal misuse of opioids. Opioids are a class of substance that include both natural and synthetic products which bind to opioid receptors. These can include natural opium-derived drugs such as morphine, as well as synthetic drugs like fentanyl. Opium and its related products were used historically and still are vital drugs used for pain relief. However, misuse of opioids is also a well-documented phenomenon which in recent decades has caused substantial mortality in the United States. When misused, opioids can cause problems with physical and mental health. In overdose, or when co-ingested with other central nervous system depressants like alcohol, muscle relaxants, and benzodiazepines, opioids can cause death. Opioid use disorder, or OUD, is characterized by the Diagnostic and Statistical Manual of the American Psychiatric Association, 5th edition, text revision, which will be abbreviated as DSM-5-TR moving forward, as a problematic pattern of opioid use leading to clinically significant impairment or distress, as manifested by at least 2 from a specific list of signs and symptoms. These include spending excessive amounts of time using or acquiring the substance, experiencing withdrawal symptoms, cravings, tolerance, and use of the substance causing persistent or recurrent social or interpersonal problems. Interestingly, the diagnostic criteria for opioid use disorder are nearly identical to those for alcohol use disorder, allowing for some comparison between the categories of problems caused by misuse of both substances. Opioid agonists are medications that bind to and activate opioid receptors. Certain opioid agonists, as stated before, including methadone and buprenorphine, have been studied and approved by the FDA for treatment of opioid use disorder. Methadone is a complete mu-opioid agonist, meaning that it binds to opioid receptors and activates them fully. In the United States, methadone for opioid use disorder is typically initiated under close supervision in a clinic setting, with frequent contacts with the dispensing clinic to monitor the treatment and limit potential for misuse. Buprenorphine is an opioid receptor partial agonist, meaning that it binds to opioid receptors and only partially activates them. Buprenorphine also has a high affinity for opioid receptors, meaning that it binds to these receptors strongly, displacing other substances with weaker affinity for those receptors and making it more difficult to displace with other opioids such as heroin or fentanyl. Buprenorphine can be administered orally and is sometimes combined with naloxone, an opioid antagonist that is poorly absorbed when taken orally, to encourage oral use rather than injection of the medication. Target symptoms for opioid agonist medications for opioid use disorder include some of those previously described as defining opioid use disorder, including cravings, withdrawal symptoms, and spending excessive time in using or obtaining the substances or recovering from their effects. Other therapeutic targets include reducing the quantity of non-prescribed opioids used, as well as death from overdose. Orthodox Christianity long predates the modern opioid crisis, which arguably grew out of a combination of factors, including the proliferation of chronic opioid medication use previously advocated for by the pharmaceutical industry, the criminalization of substance misuse problems, and the availability of highly potent opioid derivatives such as fentanyl in non-medical contexts. However, Orthodox Christianity has previously encountered problems with misuse of other substances, alcohol and food. These substances have substantial differences with opioids, including the mechanisms by which they cause harm and death, and the appropriate medical approaches to treating problems related to their misuse. However, they provide a framework for how Orthodox Christianity approaches substance misuse in general, which may be applicable to opioid use disorder. To talk about alcohol. Church fathers discuss the phenomenon of excessive alcohol use using features consistent with features of our modern understanding of substance use disorders, including opioid use disorder and alcohol use disorder, as defined by the DSM-5-TR. This makes the discussion of alcohol use disorder particularly relevant to developing an Orthodox Christian understanding of opioid addiction. For example, in St. Basil's homily on fasting, he writes, "No one has ever gotten drunk on water. No one has ever contracted headaches from drinking too much water. No one who drinks only water has ever needed someone else's feet. No one has lost the use of his feet or hands through their being nourished with water." These traits describe physical harm caused by excessive use of alcohol. Continued use of alcohol despite knowing that it is causing physical harm is a symptom of alcohol use disorder. He also writes about drunkenness, whether caused by alcohol or other passions, stating, "And in general, every passion which causes mental derangement may justly be called drunkenness. Pray consider a man smitten with anger, how he is inebriated by this passion. He is not in control of himself. He does not know who he is, nor does he know those around him. He attacks everyone and collides with everyone, just as in a night battle. He speaks recklessly, cannot restrain himself, rails, pounds his fist, utters threats, swears, shouts, and becomes apoplectic." Here he describes social and mental impairment associated with intoxication. Another feature of alcohol use disorder in the DSM-5-TR is continued use of alcohol despite knowing that it is causing social and mental problems. St. John Chrysostom writes, "When drunkenness is past, the disturbance of intoxication is whirling round both the soul and body, and while the wretched body lies paralyzed like the hull of a vessel after a shipwreck, the soul yet more miserable than it, even when this is ended, stirs up the storm and kindles the desire, and when one seems to be sober, then most of all he is mad, imagining himself wine in casks, cups, and goblets." Here he describes alcohol cravings and withdrawals, other characteristics consistent with our modern definition of alcohol use disorder. However, St. John Chrysostom also supports medicinal use of alcohol in the same homily, quoting St. Paul by saying, "Use a little wine for thy stomach's sake and thine other infirmities." St. John Chrysostom further describes a complete universal abolitionist stance towards alcohol as folly and madness. St. Paisios understood that not all alcohol use, even by a person struggling against alcohol use disorder, merits automatic condemnation. A story goes like this. Once on Mount Athos, there was a monk who lived in Caries. He drank and got drunk every day and was the cause of scandal to the pilgrims. Eventually he died, and this relieved some of the faithful, who went on to tell Elder Paisios that they were delighted that this huge problem was finally solved. Father Paisios answered them that he knew about the death of the monk after seeing the entire battalion of angels who came to collect his soul. The pilgrims were amazed, and some protested and tried to explain to the elder of whom they were talking about, thinking that the elder did not understand. Elder Paisios explained to them, "This particular monk was born in Asia Minor, shortly before the destruction by the Turks when they gathered all the boys. So as not to take him from their parents, they would take him to the reaping, and so he wouldn't cry, they just put raki into his milk in order for him to sleep." This was an alcoholic beverage. Therefore, he grew up as an alcoholic. Later, he found an elder and said to him that he was an alcoholic. The elder told him to do prostrations and prayers every night and beg the panagia to help him to reduce one by one the glasses that he drank. After a year, he managed, with struggle and repentance, to make the 20 glasses he drank into 19 glasses. The struggle continued over the years, and he reached 2 to 3 glasses, with which he would still get drunk. The world for years saw an alcoholic monk who scandalized the pilgrims, but God saw a fighter who fought a long struggle to reduce his passion. Now to talk about food misuse. Food is another substance for which there is historical precedent within Orthodox Christianity regarding its misuse. When taken in moderation and to the extent to which the individual's body will allow, food can strengthen the body and mind. St. John Cassian writes that the Holy Fathers have not provided us with a single standard for fasting or eating due to differences in factors including illness and age. He notes that a clear rule for self-control is as follows: stop eating while still hungry, and do not continue until you are satisfied. St. Ignatiy Bryankanov, forgive me if I mispronounce that, writes, "A weak body should be strengthened by food and sleep according to one's physical needs, but on no account to satiety." He goes on to write that excessive food consumption, however, can be harmful to the body, saying, "Satiety is extremely harmful even for a weak body. It weakens it and makes it susceptible to disease and will coarsen and darken the mind, decreasing a person's attention and self-control." These themes of acknowledging problems with misuse rather than any use of a substance again align in some respects to the problems that define opioid use disorder. These problems include using more than intended and unsuccessful attempts to cut down or eliminate use of the substance, which are from the DSM-5-TR criteria for other substance use disorders. These are common struggles of individuals engaged in excessive chronic food consumption. However, it is not unreasonable for a person struggling with excessive food intake to take an approach of striving for moderation rather than extreme deprivation. When asked the best way of fasting, Abba Pimen stated, "I think one should eat every day, but take a little less than you feel like eating." He also advises that asceticism should be practiced in a way that is beneficial to the person practicing it, saying, "Do not live where there are others urging you to perform extravagant asceticism which you do not find profitable." In the sayings of the Desert Fathers, there is also a story about a monk originally from Rome, well known for his theoria and discernment. When visited by a monk originally from Egypt, the Egyptian monk was scandalized by the Roman monk's fine clothing, footwear, and wine drinking after dinner. The Roman monk, who had the noetic gift of discernment, asked the Egyptian monk to describe his upbringing, which was characterized by austerity and poverty. The Roman monk went on to explain his own upbringing, which was characterized by opulence far beyond his new monastic life. Upon hearing this, the Egyptian monk had a change of heart, saying, "Woe is me, for I came into the monastic life from a background of great deprivation and toil, and now I possess such things which I did not possess before. You, however, chose to come from a life of great luxury into a life of deprivation, from great distinction and riches into humility and poverty." Clearly in this story, the progress a person makes to cut down on unnecessary consumption is considered laudable. Orthodox teachings place a high value on the preservation of life. Father Stanley Harakas writes, "Orthodox Christian ethical thought universally holds that life is a gift of God, and as such is the necessary prerequisite of all other physical, spiritual, and moral values. As a gift of God, it is a moral good held by the individual and by societies in trust, and over which they do not have absolute control. Both the individual and societies, however, are charged with the moral responsibility of protecting, transmitting, and enhancing life. The preservation and protection of life are thus seen as crucial in ethical decision-making. Since life is the prerequisite of all other this-worldly goods, such as education, intelligence, social worth, and service to humanity, it has an intrinsic value that may not be violated under normal circumstances," end quote. Opioid agonists for OUD are effective in reducing mortality associated with OUD. A meta-analysis of 749,634 individuals found that the relative rate of drug-related mortality during OAT was 0.41 compared with the time out of OAT. The fact that opioid agonists for opioid use disorder reduce mortality indicates that their use is consistent with Orthodox Christian teachings on the value of life and on the appropriate uses of medical intervention. Opioid agonists for opioid use disorder are also effective at reducing suffering associated with opioid use disorder. Individuals using buprenorphine, for example, largely reported relief from opioid withdrawal symptoms when taking this medication. Use of OAT has also been found to reduce the rate of non-fatal overdose. Dr. Harakas also acknowledges the role of the loss of ability for a person with a substance use disorder to fully control their use of the substance when he writes, Orthodox ethics, because of its teaching on involuntary sin, is able to recognize the evil of the condition of drug addiction and yet also recognize that the essence of the evil is that personal self-determination has been lost, and with it a large measure of personal responsibility. End quote. Treatment of opioid use disorder with opioid agonists can offer a person increased ability to, with the help of their doctor, control their use of opioids. Now on to some possible objections. Individuals unfamiliar or only superficially familiar with the mechanism of action of opioid agonist medication, such as methadone and buprenorphine, may argue that the use of these medications feeds rather than treats addiction, since they bind to and activate the same opioid receptors. However, use of these medications to treat opioid use disorder is substantially different from the misuse of opioids, which has caused substantial mortality historically and in recent years. First, the prevalence of mortality attributable to methadone and buprenorphine is substantially less than the mortality attributable to other opioids, especially fentanyl. Second, the mechanism of buprenorphine is such that it only partially activates these receptors, unlike more commonly misused opioids such as fentanyl and heroin. Methadone is typically initiated in a controlled clinic setting with appropriate supervision by professional staff who are able to help limit the patient's intake of the prescribed methadone to that which is indicated by their treating physician, and which encourages and increases the frequency of their contact with professional services. Third, the high affinity of buprenorphine for the mu opioid receptors decreases the ability of non-prescribed opioids of misuse to bind to and activate those receptors. So it makes it harder to get high off of them, and it makes it harder to die from them. Fifth, both of these medications are prescribed at specific doses by a patient's treating physician, limiting their potential for misuse compared with the effectively unlimited amounts of opioids that a person could obtain illegally. And finally, opioid agonist treatment for opioid use disorder is typically intended to assist people with controlling symptoms of their opioid use disorder rather than indulging those symptoms to facilitate further misuse of the substance. Dr. Harakas comments on the appropriateness of taking substances with misuse potential when appropriately prescribed by a physician, stating, quote, the use of stimulants, depressants, and hallucinogens for any purpose other than the restoration of health or the alleviation of abnormal pain when properly and legitimately prescribed by a physician is condemned. As Father Thomas Hopko put it, the scripture itself says we should never put God to the test. We should not drink poison and think God will save us, or play with snakes and reptiles, or jump off the roof and say, God will save me. The devil tempted Jesus this way, and Jesus said, you shall not tempt the Lord your God. If God provides a help through medications and physicians and doctors and skills and machines, we should thank God for all that and take advantage of it. We should not say, no, we don't need it. But all the time, nevertheless, we believe that our life is in the hands of God. It can be in the hands of physicians that God had created, God had formed, and God has sent to us for the sake of our healing. End quote. It is also important to note that administration of opioid agonists for opioid use disorder is not mutually exclusive of other interventions. These interventions can include traditional 12-step programs, individual counseling, linkage to family supports, and contingency management. In conclusion, opioid agonist medications, including methadone and buprenorphine, are medications approved by the FDA for treatment of opioid use disorder and effective. It is excessive and harmful use of substances rather than any and all use that is discouraged in Orthodox Christianity. Opioid agonists for opioid use disorder represent an appropriate, professionally guided, limited, and controlled use of an opioid to prevent problematic and lethal misuse of opioids. The use of this kind of medication is consistent with Orthodox Christian values regarding the preservation of life and reduction in harmful substance use. Thank you.
I'll go ahead and ask one. So, I'm trying to formulate the question because it's been quite a while since I learned about this, but in the context of viewing treatments for substance use disorders through an Orthodox perspective, I'm somewhat familiar, or was familiar at one point, with a method where, like, for alcohol detox, you can take a medication that will make you sick when you ingest alcohol.
Disulfiram, yes.
Yes, and so is that, I guess I'm curious what your opinion is on that in terms of an Orthodox perspective, because you're kind of doing harm to your own body to get over your addiction. So I was curious if that has implications from a spiritual perspective, like if you're inducing harm to yourself to get over the alcohol addiction.
Yeah, it's a good question. I'm not an expert on spiritual matters as a layperson, but what I can say is that first of all, disulfiram is no longer my first choice of medications for alcohol use disorder. There's a lot of potential risks there, and of course, as you alluded to, it can really cause a person to get sick if they use alcohol while on that medication. But with that being said, I have met patients whose lives have really turned around with this treatment, who were on a path to prison, loss of family, hospitalization, maybe death with their alcohol use, and this medication is something that, as part of a bigger treatment plan, really helped them to avoid using the alcohol, and who said, Doc, I know there's other things out there now, but this is what's working for me, and this is what's kept me from, you name, the maladaptive bad behaviors that led to them needing treatment in the first place. So from a medical standpoint, I would say that while this is no longer considered like the first line treatment, it is something that has helped patients in my clinical experience.
I had just heard because my minor in undergrad was in addiction treatment, and one of my instructors, she actually got treatment where she went to a facility, they gave her, I guess, disulfiram, and then she would drink while all medically supervised, and so it was like they were inducing the side effects, and so it sounded kind of problematic for a lot of reasons, and so I wasn't sure.
I don't know if there's other ways of doing things, but in my experience, that is not how we use that medication. Right? Yeah, I would not intentionally make a person sick. Obviously, that's completely out of the realm of appropriate medical ethics, at least the way I understand them. Yeah.
Thank you. I'm very glad that you went into depth on this subject because I had zero time to do so. But I was wondering, what your thoughts are. I mean, we have an endogenous opioid system, and to me, this idea that opioids are bad, therefore you can't have any of them. I completely agree with what you said. Actually, certain opioids, when used correctly, actually can help the problem. And I feel like the fact that we have an endogenous opioid system, meaning we have internal opioids flowing around,
absolutely,
orphans, that means there is something our body is supposed to regulate our relationship with opioids. It's not supposed to just be all or nothing, but I don't know if you have thoughts on the endogenous opioid system.
Yeah, I mean these are neurochemicals that we have in our bodies, and even dopamine itself is a neurochemical that we have when we throw it out of balance by introducing, drugs of misuse or abuse. We can definitely throw that off kilter, in which case it's really important to get treatment for it. But to say that the treatment itself is the problem, I think is the wrong focus. It needs to be on restoring the function of the person who has come to you with a problem that came about not because they were out there getting prescribed unlimited fentanyl by a doctor, and sometimes that does happen, but usually it's the case that these are people who are using substances that maybe started as a legitimate prescription. I'm seeing that decreasingly now, but that they're getting off of the streets, and it definitely adversely impacts their own body's ability to produce and respond to the right level of endogenous opioids, and therein lies the problem. So you're right. We have these endogenous neurotransmitters, and we can try to restore some degree of balance with medications, but of course, sometimes it can be a very long process. And I know the topic of rapid tapers was discussed as well, and obviously that can take a long time for the brain to heal, to change the number of receptors in the brain to one that is consistent with a person who has not had that history of opioid abuse to back to more or less normal levels. And that's why I personally don't put a time limit on saying, you know, it's been 2 weeks, or it's been 3 months, or it's been 1 year, or it's been 2 years. Like, and now we have to cut you off no matter what, independent of any psychosocial considerations.
Can I just make from the position of improving the quality of life, methadone is such a great drug, in my opinion, to also help patients who have cancer with their pain management.
Yes.
And some of our patients are on methadone for years, and I truly believe that it helped them to even address the existential concerns when the pain and symptoms are managed. They are more relaxed to think about things like, where is my connection with God? Am I alone in this? What's the meaning of all of that? So just saying that it has really great use. We can put all of these medications to actually help people to improve the quality of life, and even in some ways to draw closer to God, in my experience. So really appreciate what you do.
Great, thanks.
Yeah, because when you're in pain, nothing else matters. Nothing else matters.
And of course, there are risks with any intervention for physical pain, but ultimately, you know, if somebody is suffering, you have to do what you can to try to help the person in front of you. And sometimes, not always, but sometimes that's going to include things like methadone or other opioids. Yeah.
Actually, I'm glad that both of you are here because I want to ask some questions. Because so I'm kind of on the different side of it because I'm in management, and so one of the things that I've always tried to manage people's pain as well as I can, as carefully as I can. So you know, physical therapy, NSAIDs, you know, injections or block epidurals. That's the way. But there are patients, like you discussed, where they have failed back syndrome, and despite all those interventions, they still have tremendous pain, and it really limits their life and their ability to be functional and their ability to enjoy life. And so there comes up a point where, okay, am I going to start this person on an opioid medication and perhaps give them a measure of their life back, or not? And a lot of physicians have chosen not to. It's like, you know, they allow their patients to then suffer in pain, and then they go start to seek medication out, and that's where perhaps where some of that spike is coming from that you referenced. I'd love to hear your perspectives on like what cautions do you have to this side of it, as far as like the pain management side of how would you approach managing your patients. I try to keep my patients below, because I actually use buprenorphine to treat pain when I can, because I think it's safer, and it treats pain and it's safer. So I'll use, maybe go up to the 36 morphine equivalents for that. But in general, the vast majority of my patients are below 30 morphine equivalents. But how would you, I mean, how would you speak to that?
I mean, you're probably more of an expert on pain management than I am, of course, but I'll say...
from your perspective, how would you, from what you see, where do you see red flags with that?
I would be screening proactively, and I'm sure you do, for symptoms of the use disorder, you know, DSM-5-TR, because, again, to emphasize, use of the substance by itself is not the problem. It's where it starts to impact function, where they start having cravings, withdrawals, those kinds of things, and that would be my recommendation, and not a specific MME, you know, cutoff, but rather an individualized approach.
Go through a screening before you place them on the medication. The opioid risk screen.
So it's funny because when you screen for use disorder, and if you decide use disorder is present, you and I probably would still put them on opioids. We would just change the type of opioid that they would go on to.
That's a good point.
So you're more asking of when do you start introducing opioids to a person?
Well, yeah, just safeguards.
Yeah. So I think that this has come up, I think that there's been a big pendulum swing away because of all the deaths, and now people are super afraid to even offer a single opioid to a person. But I think that when you look at the older literature on this, this is like the 1990s literature that was coming out of pain management that kind of led to the proliferation of more opioids. before it got super demonized, as the cause of all these deaths and stuff, they actually just had the same kind of question of like, how do I use opioids where it's still benefiting the person, and at what point does it start to not benefit them? And their major limitations were actually the development of tolerance and dependence became the problems that they were working around. And so when you start opioids, in order to make the person more functional, setting aside the sort of stigmatizing nature of opioids and the crisis that we're in, you actually logistically end up with a problem anyway. And the problem is that the person's going to become tolerant, they're going to become dependent. That opioids, the dependency on opioids can create a new type of pain for them. Mm-hmm. And then you have the newer research about hyperalgesia, which is that like now your brain maybe is trying to rework a new neural circuit to get you to feel pain, because pain is our body's warning system, so you can't suppress it forever. So there are new problems that do come about starting someone on chronic opioid therapy. But I would say that still doesn't mean you never started. I think that you have to balance like their functionality and their quality of life, and then you have to keep an eye on, okay, periodic drug holidays maybe, rotation of opioids to make sure they're not getting overly tolerant to one. Different opioids have different pharmacokinetics that you can like enhance the effectiveness of. So like maybe they're on too many short-acting opioids and they need something sort of longer-acting so that they don't get so many spikes in their reward system, so that you don't put them on a path towards addiction. So it's just, there is strategies within opioid prescribing that you can use to try to optimize the functionality with minimizing the harms. But even when you do those strategies, you do still run into these problems of like tolerance dependence. But yeah, if they develop opioid use disorder, my plan is then to rotate them to a longer acting opioid, and I still don't cut them off from opioids. So that's like addiction to me is not even the worst scenario here. I still have a plan for it, but more is like, am I actually over time giving them a new form of pain? That's I think the actual dilemma of like, when are you gonna pull the trigger? Yeah, which I think is hard. I don't know that we know the answer.
Right. Well, it's super nuanced.
Yeah.
And it's also very. I'm grateful. I actually have. I get to see my patients frequently enough that I can kind of keep tabs on that. But it's always took as me kind of a little bit of a gut ache too.
Yeah, but I feel terrible about all the people that basically can't access any alleviation of their symptoms.
Right.
And we have gotten to this point in society where it is easier to get drugs on the street
Very.
than to get a doctor to treat you.
Yes.
And I do think that like you can't just abandon everybody with pain.
Right.
Yeah, and it just takes one dose of street fentanyl, which pretty much everything out there is fentanyl now. And you're dead. Dead. Yeah.
Thank you.
so
Thanks
much.
for your presentation.
Thank you,
both of you. Obviously, those conversations can't